pulse wave, you're gonna do your color compares. Okay, so you're gonna turn a color compare on. So you have a B mode on one side and a color compare on the other. So you're still getting the same parasternal long.
Okay, then color on both of them
Color on both valves.
at the same time.
Yeah, you can either do color compare or you can do what she's doing.
Oh.
Okay.
The gray.
I was taking two different
you
pictures.
want that sector that big?
It
Yes.
depends though. You need to check. Is your image, does your B mode image look like crap when you turn the color on when you do this? Then I wouldn't take it. I would take them separate, but per patient, figure it out. Okay, so she's got color on both valves for this one. All right, now you're gonna go to RVIT. You have to type it. I know. We have to fix presets.
I know. Add it to the list. Oh, hold on. That makes
Set
me
your
wanna.
home.
I know. That's what I was gonna do. Set home. There we go.
Would you say set?
You can set home.
So
which
notice
means-
how it kept wanting to default to writing down here.
Yeah.
I set its home to up here, so now whenever I type something, it'll type
It's
up
stay
there.
up there.
To do that.
So I
It's-
have label, and then I hit set home.
Wow.
Yep. So you put your cursor wherever, hit set home, and then look, it wrote there. Yep. Alright. Would you prefer color compare?
That's up to them.
Okay.
But I mean, mainly that's what we do in the field.
See, we don't do that at St. E's.
Okay, well, we do it at
So
Mercy.
it's completely whatever you prefer, whatever you prefer. Because once you get onto the
Yeah.
field, it completely depends on the hospital
And the doctors.
and the doctors.
The doctors are the main problem.
Got some TR there.
A huge problem.
And then this is when we do
Now you're gonna do continuous wave.
hit my CW. Now, just like with carotid, you can hit this middle button above your cine ball to take you back to your duplex image. So that way you can make sure you are right in between the valve leaflets. You can make sure you are picking up that regurgitant flow. And then you just hit that center button again.
Do you want the color in it too, or
Yes.
does it matter?
You have
Yeah,
to
so
use the
this is-
color because we need to be able to see where that regurgitant flow is.
This is called it like a triplex. Okay, because you got all three functions. You got color, B mode, and spectral all on there. Okay, so now you're gonna go to RVOT.
Ooh, look at that PI.
So this means your pulmonic valve is leaking a little bit. You see that little jet right there?
That little flame.
Yeah, the little red, that means it's going the wrong way. It should all be blue.
And how do we know it's supposed to all be blue? Yeah. Yeah, our color bar. All right, this one we also throw some continuous wave in. So what I usually do is I usually turn it on and then I fine tune it. Then I go back to my reference picture, make sure I'm in the right spot, make sure I like where I'm taking this.
Let's turn that down for them. It's too fast. So they can measure better. There.
So this right here, that is that little bit of regurgitant flow we're seeing.
But this is the flow across her pulmonic.
This
Okay.
flow right here is the regurgitant flow.
That you have to think about. This is why your EKG comes into play, because you need to know what cycle is the pulmonic valve opening, and it should be opening during what? Systole. So see where systole is? Look at that, right where the pulmonic flow is.
Oh,
coming
what
through.
else happens right here, guys? In our EKG class, what happens here electrically? Yeah, that's our depolarization. So then right afterwards is when we have our contraction. So look at that. Right after our QRS is when we have our systolic flow. It's all coming together. Do I need to do anything else with PLX?
No.
I'm not doing M mode. If there is M mode. Okay. P-sash.
No,
we'll do
there's no end
hat.
mode on this one.
I don't think there's P-Sax cut.
Oh, there's
I
not?
think it's just mitral and base.
Hold on. There's just mitral, base level, and continuous wave.
I'm still getting it because it's pretty.
That's pretty. She's got it really pretty. And this is due next Thursday,
Absolutely not.
the 16th.
I can't remember off the top of my head.
I think it is.
It's
It
next
is.
Thursday.
It's next Thursday. It is next
Remember,
Thursday.
that's what she said. That's what she said.
So you gotta
Not
make sure you
us.
put color on
Not
it.
us.
Then you go to your base view.
I think she's here on Thursdays.
I'm here on Thursdays.
Oh.
Are you?
Cute.
Okay, so she's gonna get the B mode, and then she's gonna put color on every valve to focus
How many
on
valves do we have in this one?
3.
3. Yep.
So there's our aortic.
Oh God, I'm not zooming up on that. My gosh.
You have to turn it all the way down. I don't know why it
I
does
don't
that.
understand that though. But now it's fine.
Okay.
Whatever. And then we'll do tricuspid.
I don't understand the color.
The color yet? You're
It
not gonna
just-
understand it
It
yet.
just like looks so chaotic. Like
It is.
I don't see how you guys can tell where exactly everything.
gonna
So
be-
that blue blip,
It's gonna be a little bit.
that's TR. That little red blip.
Here, freeze it. Go to TR, and then freeze it once you get one. Okay.
Oh, right there.
See this right here? The flow should not be going away from the transducer on the tricuspid valve.
Because remember, this is our right atrium. This is our right ventricle.
It
Normal
should-
flow should be right atrium to ventricle.
It should all be red in here, and it's
Towards
not. So this little blip comes through, and that's the problem. It comes through every cardiac cycle, so that's why it's hard to understand. It looks chaotic because it's live, and it's every cardiac cycle. So, you know, she's at 67 beats per minute, and that's what we're watching.
Mm-hmm.
So that's why it's hard. You have to kind of like slow it down to understand. But this is what we do all day. We're so used to seeing it that we know that that's it, and then we know how to get our pulse waves. But you guys don't know how to do that yet.
Especially
You're
the
just
very
learning how to turn the
minuscule
color on.
ones. Yeah. It comes
You're
with
not
more
learning
exposure.
disease yet, okay? Disease stuff comes next semester.
Yeah, it definitely happens more with exposure. All right, is that it for?
You got to do continuous wave.
Oh, and both of
tricuspid
those?
valve, yep.
Oh, got it.
So what are the things you can adjust when it comes to spectral?
Baseline.
What else?
Scale.
Scale.
That's a big one. Yep. Watch if I overgain that. That looks gross. Watch if I undergain it. That's not bad. But definitely I want to make sure I am seeing all the parts adequately. Now I'm going to the pulmonic.
You see how she didn't back all the way back out?
I just did the thing where I used that middle button right above the cine loop.
A lot of people get themselves into a point where they back out and then find the picture again and then put their continuous wave in. She didn't have to do that. She just switched from that side to that side just by leaving it in triplex mode.
Any questions about parasternal before we move on to apical? Cool. All right, let's do an apical 4. Then I'll do VTIs in this one.
Okay.
And there's no measurements on this one.
Not this one, but I am gonna show you some because I think you do have some for the proficiency. Lean back a little bit for me.
I think she said for proficiency we have 3 measurements.
I
Yeah,
think so,
we
yeah.
have it. Look at me.
She's so prepared.
We have it.
A little foreshortened though.
There you go.
There we go. So watch. I was up here. These are really pretty pictures, but look at that apex. Look at how that apex is coming down into her cavity.
Here, pull the focus into it too.
And also,
See
let's
how this
do a
comes
rose.
down?
We don't want that.
We want it to be a V.
because this is not giving us an accurate view of the apex. This is what we call do we call it a fade? No, foreshortened, just foreshortened
Foreshortened apex.
yeah. So if you see this, typically going down a rib space,
Now you see how it opens it up better.
hold on,
Because what happens
there we go.
in a lot of AFib patients is that we miss that if you foreshorten it, and that's where a blood clot can hide in the apex. And if we don't catch it, then
Take a
it
small
could
breath in for me.
dislodge and
Right there.
shoot through their heart into their aorta.
Beautiful.
So,
Breathe. Look at having her take that little breath in. Watch. So this is her without a breath in. Still a good picture. Take a small breath in. A little bit bigger. Hold it right there. Just kind of clears it up just a little bit more for us. Let's just do the endocardium. Go ahead and breathe.
and the endocardium is what?
Lines the chambers and the valves.
Correct.
And that is the most important thing we are looking at always when we're doing echo. All right, so what valve do I have color on right now? Mitral, yep. So this is where I'm gonna show you different measurements. We're gonna do pulse wave first. When doing your pulse wave measurement, you want this little cursor to be right in between where those leaflets are opening. You want it right at the inflow of the left ventricle.
Because what is pulse wave different from continuous wave?
Pulse wave is marked for low velocities.
Well, pulse wave is what?
Pulse signals to have a listening time to see the
What does our sample gate do?
Oh,
On
it
the
gives
pulse
an
wave. Exact
location.
location.
So I am choosing the exact location. I am wanting it to get a Doppler.
We want just the inflow to the mitral valve, so you have to place it there. If you do a continuous wave, what's a continuous wave line pick up?
Takes everything in that line.
Like everything goes to the valve?
Every
Okay.
velocity across the valve.
That's great when you want to get very high velocities, but I am wanting a very specific place when I take this measurement. So right where those leaflets, right in between them as they're open, you will see a nice little M with a bigger, what we call E wave, and then a smaller A wave. What's in our calc package here?
There should be an E in there.
Okay, let's go back. So, to take an E to A ratio, which you need to do for your proficiency, you will hit measure. Over here, you want to hit mitral valve.
Peak.
Or would it be, this one might be better, right? Because they might do it all. Whatever, we'll do this one. All right, you'll hit peak E velocity, which is this guy. So just like what we did with carotids with that peak systolic velocity, we're measuring our peak E wave velocity. And then you hit the A wave and you do this little A wave velocity. Very similar to carotids, but instead of a peak systolic and end diastolic, we are measuring these 2 points.
What did you press again on the machine?
So I'm gonna take that. Let's
There.
take
Oh,
it
she
off.
went to
Hold on, let's take it off again.
Yeah.
Oh my god, now all together. Get out of here. Okay. All right, hit measure. There are the different valves on the side here. You want to hit mitral valve, peak E velocity, and then peak A velocity.
And once you take them, they put a check mark by them so that you know you've taken it, because when we get further down the line, there's going to be multiple equations that come out of making sure you have all these things check marked. So if you're like, oh gosh, why didn't my AVA come out, which you'll learn later what that is, you might be missing something that you didn't measure. So you can go back and measure that.
All right, so
And I gotta
same
do
thing.
continuous.
I'm actually gonna go up to do this one just because they're so easier. So now I'm doing continuous wave. Same thing, big E wave, littler A wave. And this one you're gonna hit measure MVVTI. That is our velocity time interval. We will discuss that. I'm assuming we discussed that this term, right? I hope so. What you are doing is you are tracing the inflow of the mitral valve. So you are tracing all the blood that is going into the LV during diastole. So I literally just traced it. That's all you gotta do. Then you hit acquire, you get all of these different measurements. You will know what each of these means at a later date. But just from measuring this waveform, the machine is able to compute all of these different things for us.
You're ignoring that kind of outlier.
What outlier?
Right here?
Yeah.
Yes.
Okay.
So,
I was like, where?
I know, that's what I'm like, I don't even see it.
I'm looking sideways.
So
I can't see it.
you,
So what we talk about is we don't want to do like that one little guy that's going a little bit faster than the rest of the medians.
like with this guy, I would do it right, I would measure it to right here and not do that little extra blip because that is an outlier there.
Okay.
I mean, that's me being super picky, but yes, in that situation, you ignore those extra ones.
So unless it's like really high amplitude, you're just
Mhm.
like, oh,
yeah.
Because sometimes your mitral valve, instead of having a nice M like this, it almost does a more like this action.
That
So-
means the valve is busted.
Yeah. Busted.
Busted.
We'll do our,
So now you gotta do right.
we'll do our
Now
right
you
side.
see how she swayed a little bit to look at the right side better. She's pulling the right side in. She's trying to pull it
Trying.
in better.
And Jackie said that your best B mode isn't going to be your best color and isn't going to be your best spectral.
Correct.
Correct.
You gotta move around.
So that's, at my hospital, our doctors hate color compare. They actually do not want us to do color compare. In their eyes, they say it degrades the image too much. I get whatever, they're the ones reading it, but that's why it's do whichever one you feel more comfortable with, whichever one looks better on the machine.
In the real world, would you get like the like better picture and then move to spectral, or is it just the like spectral picture with the B mode and color?
You want all of them to be good on their
No
own.
matter what.
Yes.
So for us, our doctors like color compare because they're already looking at 100 images.
Mm-hmm.
And they want to minimize.
So what happens is if I find something on the valve that I need to investigate, I turn off I give them their color compare,
Mm-hmm.
but then I turn it off and I go dive deep into that whole thing, and I do a lot of extra pictures to check to make sure that I'm getting everything. I zoom in, I do X-plane, like I think I showed you X-plane, like there's all kinds of fancy gadgets on here that we do to look at things.
What am I getting here? Continuous
getting-
impulse.
You're getting continuous and pulse.
Okay, same thing. Put that pulse wave sample volume right as those leaflets are opening, right in between them.
You don't
We're
have to measure
wrapping.
anything on that.
That's your TR coming through. So, not measuring, but we still have a nice little M. So both of our AV valves will have a little M as their inflow. Now I'm throwing some continuous on there. And this, we're gonna be able to see her regurg. So you hear that sound? That right there is her regurg coming in.
So you can see like it's coming through at the wrong time, right? The blood should go through the tricuspid valve during diastole. Well, this is systole, so there's a leak coming through.
Because that is when your tricuspid and mitral valve should be closed. But there is a little bit of leakage. Little bit's fine. It's once it starts being significant, that's when it can start affecting the rest of your heart. Is that it for 2-chamber? Oh, and then 5.
4.
That's
Yeah,
what I
you gotta
meant.
go on to 5.
I was thinking in my head,
It's okay.
2-chamber.
5 color, LVOT, ABVTI.
Okay.
She only wants an ABVTI.
Not an LVOT one?
She wants an LVOT pulse wave, but she only wants an AVVTI.
That's fine. I can
Read
do
on
whatever.
storage.
So, got a little bit of insufficiency or regurgitation there.
I bet.
So let's do pulse wave first. So this one is going to be a little bit different. When we do pulse wave of the LVOT, we are doing it right before the aortic valve. So I see my aortic valve right there. I am going to put it just before the aortic valve. Right? It's a noisy bugger.
It should be.
If it's not making noise, then we're concerned.
The aorta is the loudest.
So, you got a clear spectral window. Here's the blood shooting out of your heart. These right here are actually valve clicks. So I am so close to the heart, I'm actually getting a little bit of click from the valve. Not measuring anything. All right. Then we're gonna do continuous wave. And this one, you wanna make sure you are completely through the aortic valve. So this is the one we use to see what our highest blood flow is through the aortic valve. So we want to make sure we are smack dab in the middle. And we are giving the doctor the most accurate measurements.
VTI.
So this one's also VTI.
She
So-
wants them to see the mean gradient.
Okay. So this one we're going to go to aortic valve. Do AV VTI. Same thing with mitral. We are going to trace the aortic valve flow. Why is it below the baseline?
It's away from the
Yeah, it's moving out of the heart away from the transducer. So here we can get our max velocity, we get our mean velocity, we get pressure gradients, we get all of this stuff. Just hit acquire, saves all those images, all those numbers.
Okay. She wants you to do 2-chamber, but she wants an LA volume,
Okay,
right?
okay, okay, that's fine. Am I still doing color?
Yeah, you're still doing color.
So we're just doing a little bit of all measurements.
We're doing spectral and pulse wave again and 2-chamber,
Okay,
but then she wants an LA measurement.
okay. So where am I putting my sample gate for a pulse wave?
Just right after the leaflets.
Mm-hmm. Yep. So right in between them, as they are separated.
You're above them.
Yep. And
Now
then
you kind of see them close.
here, let's
So
And
we
you
want to
want-
get them when they're
hold on. Let me do this.
open or
Let's do
when they're
this.
closed?
It doesn't
So,
matter.
Watch.
We just want to be above them.
Be above them, right above the leaflet tip.
So
Watch
here's
her.
my cursor.
Yeah.
See this circle right here?
Yeah.
This is
That's where.
determining where my sample volume is going to be. I am going to put it about right here.
See how it can almost touch it?
So about right there.
Okay.
So I'm not too close to the valve. I want to see the blood as it's coming into the LV.
Okay.
Okay. So this one I gotta do continuous wave still. Who's that?
Rachel?
Oh, it's
I don't know
Rachel. I'm like-
people's voices, guys.
I'm like, who the heck is
Everyone's
screaming?
in here. Hi.
Hi.
And then we're doing
I just have a. We're
You need me?
just really, really fast.
LA.
Okay. And then what am I doing in here? Let's just do a disc maneuver. I got it.
This is
Oh,
the one
no.
I have to put. You want to put them up there?
I'll just put there. It's fine.
Okay.
All right. So to get an
sorry.
LV measurement, when we are measuring the LV, we want it. I'm sorry, LA. I'm so sorry. LA measurement. When we are measuring the LA, we want it at its largest. So right before it opens up. So this is when you just kind of watch it for a little bit. Like, oh, I like that image. This is when you want to use Cine. So roll back. And you're like, all right, right at this point is when it's its biggest. Because if I go any further, that's when it starts contracting. So right there is at its biggest. Right before those leaflets open up, I'm gonna hit measure again. Hold those for me, thank you, madam. Oh, hold on. And we're gonna do LA A2CS. That means LA apical 2-chamber.
No, that's great. Okay, I just see why.
You're gonna start right here. Which side of the heart is this? Which wall?
The
We're in 2 chamber.
Is it
inferior?
Inferior, yep. So you're gonna start on the inferior side of the valve over here.
so much, Kelly. You're welcome.
Hit your key to start tracing, and then you are going to trace the whole LA cavity. And you are going to go around until the anterior side of that annulus.
And once you push the other button, it'll calculate all this.
And then I am in control of this. Oh God. I've never done that, so I didn't know they would do
Why
that.
would you do that?
So what you want it to do is be directly across. I'm
It's
crazy
okay.
sometimes. Sorry.
Is it okay that it's got a little bit of that valve in there?
Yeah, I could
She
probably
just
move it
moved.
down.
She just moved the whole picture. She just went nuts.
It should be down, like right there. Yeah, yeah.
But right below it.
Yeah. Yeah, I went a little crazy. I apologize. Is this it for 2 chamber?
That's it.
Okay.
As long as you did your pulse wave and
I
continuous
did.
wave.
I did.
Now you move on to apical 3.
And 2 chambers, the one that's true inferior and true
Yep.
anterior, right?
Mhm.
Okay.
You're gonna do color, and then you're gonna do continuous wave over the mitral valve and aortic valve.
Measure anything?
Nope.
This 40 minutes too?
This one is 40 minutes also.
But we're not measuring.
Huh?
We're not measuring on this one.
You're not measuring.
Oh.
You
We're
are
just showing you measurements because that's coming up
On the PE.
on the proficiency at the end. Yeah,
Okay.
we're trying to show you ahead of time so you can practice them.
How much time on the proficiency do we get?
I think it's an
It's an
hour.
hour.
Proficiencies though are
Serious?
you're doing everything we taught you. Do they do volunteers this year?
No,
Okay.
we'll only
Do we
bring them.
choose who they scan though?
Yes.
All right, over aortic valve, throw on some more continuous wave. Make sure whichever valve you're looking at, make sure so at the aortic valve, don't give me this because then I can't see any of the aortic flow. Make sure it's like this. Same with mitral valve. Don't give me this. Nope. This is the main thing I'm concerned about.
So this is basically us trying to see that you know which way the blood flow is supposed to be going. So you know that that's for the mitral valve. You know that's for the aortic valve, that it goes the opposite way. You know that the pulmonic goes the opposite way during systole. Like, we're just trying to see that you can turn these things on and figure it out.
Anything else?
That's it.
Cool. Anyone have any questions?
So,
Sorry,
no
you
can go.
SSN or
Huh?
xiphoid or any of that?
Huh?
No xiphoid?
No, I don't think so, do we?
Not on this.
Nope.
Is there a
Okay, cool.
superstar at all?
Nothing. Nope. Look at that. So easier.
No labeling, anything?
No labeling. Just labeling where you're at. So apical 3. And you see how she just put A3? You know, we don't need apical all the way out. Like, make it simple. Okay?
Keep it simple.
Keep it simple. So you're really doing on this PE, you're doing B mode, color, continuous wave. Okay? You're doing pulse wave on certain ones. So you got to make sure you're doing pulse wave on certain ones, which is the mitral valve, the aortic valve, and the tricuspid valve in 4 and 5, not in all the other views. Okay? So just make sure, and then you're just going through your apicals, color, spectral. So there is no subcostal, there's no suprasternal notch this
Take that breath in
time,
again.
But that's on the proficiency.
but that's gonna be on the proficiency.
Okay.
See how she had her take that breath in and it
All
cleared
right,
it all up?
breathe. I had to move quite a bit with her though. Definitely start getting in the habit of having your patients breathe. Because if I stayed in one spot, so if I don't move, take the breath in. Look what happens. I have to move with the heart as she is breathing. So take that breath in again.
So
I
kinda
am
move
kind of
medial.
pushing up. I am going more medial. And look at that difference. That is a big old
Think
difference.
about when they take a breath in, like the
Look at
lungs
the difference in that one.
go up,
And
right? And you got to move in
Oh.
to get your view. So you want to, as soon as you have them take a breath in, move your transducer so that you can see it. And if it screws up the first time you do it, try it again. Just keep having them try it until you figure out what the movement is. And it's not going to be the same movement on every patient, okay? So you got to learn how to, yes, the heart's this big, but I got to move a little bit to try to get a better picture.
Why did you
What
like
color?
turn this color?
Yeah.
Oh, this is just me messing around.
Okay.
Nope, this is just
showing
me.
you.
Purple color.
Like,
Because you're still, nope, you're still standing around me. So I'm like, well, let's.
She's just
Impress
showing you
them.
different things you can do.
Let's
on it.
Like,
Chroma mask.
So the reason we do this is because if you think about being a doctor that's looking at black and white photos all day long, and you want to see a better picture of, I do rainbow.
And that's so funny. Okay, Kelly prefers rainbow. I prefer thallium. I don't know
Yeah.
why. I have
So-
always.
It's so that they have something else to look at to watch all these walls move besides the grade.
But then
Right?
also,
Because you get sick of it. We get sick of it. Like we're in the middle of scanning. I will show them. I will give them their black and white, and then if I'm focused on the ventricle, I'll give them this other color just to look at it because you get sick and tired of looking at black and white all day.
and remember the endocardium and how well it's moving is the most important thing we're concerned about. So a lot of the times, I mean that's still a good image, but a lot of the times this will kind of just bring it out a little bit more and give you a little bit more contrast so you can see it better.
It does look a lot more clear.
Right?
The colors.
Yep. And it's all preference. You can use whichever one. It's all preference. I don't like the slate. I've never liked slate because I feel like it's just very, I don't know.
You and I are opposite.
I know. It's funny. All right. Any questions? Anything you want me to show you?
Are we switching
You want to show them
partners
this cool
again?
thing?
I mean, it's,
Or are we waiting
It's-
until after cardiac?
That one was cool.
oh, probably wait until after cardiac.
Okay, I'm going to show you this cool thing. You're going to hold a 4. This is for, we're not letting you guys do this now, okay? But we want you to know that when you have a super hard patient and you have to hold it for a long time and you're afraid to move because every time you move it changes, you can push this button and go to 2 chamber
Oh,
without moving the transducer.
look at how beautiful her little coronary sinus is.
Now,
Can't wait to get a job.
Go back.
Hold up though. I will warn you, you cannot use this on every patient.
right, you can't.
And you have to be diligent because you could very easily give the doctor the wrong information if you don't recognize that was not an actual 2 chamber.
That's why
Hers was
we're-
beautiful.
That's why we're showing you this, but this is not for you to use yet. There's 3.
Look at that.
Wow.
I didn't move. I angled up. That's
Okay,
it.
now I'm gonna use your angle.
That's what Jackie's
Okay, so here, watch this. We're gonna use I rotate. Say it is off axis. Say that 2 chamber when you did this looks weird. You can turn it.
Ooh.
What the hell?
It's 325, isn't it?
Yeah.
No, you guys didn't tell us anything.
Yeah, you're not allowed to know this yet.
Look at that. I turned it to 325, and that's about where a 2 chamber is on a heart. And then I want to go back to 245, and that's about where it is for a 3 chamber.
I did not
Give or
move.
take.
I
She
have
didn't
not
move.
moved.
Wow.
She didn't move.
Y'all don't use this though. And I'll know if you did.
Yeah,
It is
it
a-
tells on you. It tells on you when you use it. But.
You do not need it on anyone in this room. Everyone here, you can very easily, with
And
a
then
little
hold on, we're
finagling.
gonna show them the other one. Ready?
Oh, X-plane. Hold
Okay,
on.
now watch this. This is another tool we use. It's called X-plane.
So this is essentially taking one image and then taking 90 degrees from
And
it.
splitting it.
So whenever you have masses or anything, you usually want to throw X-plane on to see if you can visualize
Yeah,
it in the other
I'm gonna
plane as
I'm
well.
gonna do it with your valve. So say I want to do more stuff to the mitral valve and I want to look at it because there might be some kind of ickiness on it. Okay, see how close I got that mitral valve? Now I can take X-plane and focus on it at the same time so we could watch if there's a clot or something or vegetation on it all at once. And you can also turn,
Sorry, I had to accept it because it was pretty.
yeah, and then you can also turn color on.
But this is a lot and it messes with your
Yeah.
frame rate. So this is good in situations where you need this. You do not use this on every person.
No. I'm
This
just
is
showing
with
flashy
disease,
stuff.
yeah.
Would this be something you would use on like a myxoma?
Yeah.
Yep, that's exactly it.
Yeah.
All right, anything else y'all want me to show you? Okay, because we don't have much time left. Gosh, have a gorgeous heart.
I love Sarah's heart.
It's so pretty.
So fun to skin.
Oh. All right.
My little eustachian valve.
I know. Especially in your, hold on. Let's show everyone the eustachian valve because she does have a cute one.
Okay.
Was she the one that had the Chiari network too?
Yeah.
Okay.
Well, actually, I think that was me that had the.
I couldn't
Chiari
remember
network. I
which one
can't
of you.
remember. It was one of us. She might have the
You
Chiari
mean
network
Zermatt?
actually.
Oh, yeah.
Oh,
wow.
It's just a remnant.
So what is the eustachian valve?
It's from
embryonic.
Fetal remnant.
And what did it cover? What was it used to cover?
intraatrial septum.
Coronary sign or the IV.
The IVC.
That's one of the two.
Yep. So sometimes I could have sworn it might have been
It
you
may
with the
have been
Chiari.
you.
Yeah.
Was it? Yeah.
No, for sure it was one of us though. I remember talking about it. Right
it's nothing to be aware.
No,
like,
the Chiari
really
network.
weirded
No,
out by.
the
It's
thespian
just
is
something
for the
that
coronary
happens.
sinus.
Yes. Yes. Yep. So there's a little eustachian valve.
So would we be able to see a thespian valve?
No.
Any of this? Okay.
Oh, you can actually see it going
Mm-hmm.
completely over too. All right. Anything else? We only have a couple minutes.
You need towels?
No, I'm just saying we only have about 15 minutes.
I don't know what else to.
Show
You guys are all using your image boost.
Mm-hmm.
and make sure if you need to, you switch from res to pen.
Yeah, change this guy up.
I will
Okay,
show.
so
Let
use-
me show a difference with that one.
Oh, I'm sorry. What?
'Cause look at the
Sarah's like,
difference. I know.
You okay?
No, you're good.
Image boost.
What? Right here, this button. We're turning it off.
Watch how much it changes. Quite a bit. So watch right now. I'm in pen. Now res, or Jen, I'm sorry. Now res. Not much of a difference, but look at especially this near field. Look at the difference between the pen and the res. Quite a big difference.
And then adjust these sometimes. Adjust your TGCs at the top to kind of see a little bit more of the apex sometimes do. There we go.
God, I can't get over how pretty your heart is. What do we think this is? This bright.
The moderator.
Yep, that's a moderator band.
Oh,
Yep, completely normal.
weird.
Definitely recognize that it's completely normal. Don't think it's a clot or anything. So yeah, that guy right there. That's the moderator band.
Hers is so cool.
I know. Her everything is so clear though. Any
So the backflow for her is not
Nope.
concernable.
Nope, not at all.
80% of the population has leaky valves. We do.
Hmm.
We found out in here.
As long as it's not significant. Because think about it, it's a valve closing, there's always gonna be a little bit of backflow.
And you have to think like we're all made differently, and maybe just one teeny tiny little part of the leaflet doesn't touch, and that's okay, as long as it's not creating the patient's symptoms. So like when they have a lot of symptoms, like her TR, if it got really bad, where's it coming from? Like where would it back up? Where's the flow come from to get into the heart on the right side? Where does it come from the right atrium?
The vena cava.
The inferior and the superior vena cava, okay? So if there's a problem and the volume of the flow is not coming, it's coming back at us, that flow is gonna back up in the legs and the arms.
And that's why we get edema and leg swelling.
Bilateral edema and leg swelling.
Now
So when a doctor orders, oh, you should definitely, we think you have a blood clot. Not always. We look in their chart and say, oh, look, they have congestive heart failure. That's probably why they have swollen legs. So things you have to think about. Not only are we looking at the heart, but we're looking at where's it backing up to. So the LA, if it was having a bad leak, where would it back up to? Where?
So that's when you
The
get
lungs.
pulmonary edema. Yep.
So it all coincides with one another. So that's where we're going. We just want you guys to learn all the basics, and then we're going into all
That's the
other
fun
stuff.
stuff. The disease is the fun parts. I'm just hanging
You're just
out.
hanging
I'm just
out.
hanging
I don't know
out.
if this matters anymore, but when I was just doing my PE, it kept changing from like 3 beats to 2 beats. Like, is there a way to keep it on 3
Were you
beats? Like,
still
I had
on
to
that
keep
protocol?
I bet she was.
Oh, that
You
probably
were
was
still on
before
that
you told me.
protocol
Okay,
thing.
because I kept like just switching it to 2 beats, but I was doing it. Okay.
Yeah,
That's
that was
probably
during
it.
that protocol thing.
All right. Well, that took more time than expected, so I apologize. Oh.
Really?
Made a nice donk too as it
Good-
skipped over it.
Good thing you're not a basketball player.
Thank you for being a beautiful scan
No
subject.
problem, thank you.
I will post this